I think we'll start. Morning, everybody. Welcome to Grand Rounds for May the 8th. I am going to give the introduction for Dr. Shapiro, who's our presenter today, but Dr. Kavesi is first going to do the land acknowledgement today. Go ahead, Tom.
Thanks so much, Hillary. So as many of you know, I believe in changing up land acknowledgements because otherwise they become rote and they lose their power. So my favorite acknowledgement, I learned from Algonquin comedian, and it runs as follows. So right now I'm sharing my office with Dr. Shapiro, who'll be presenting momentarily. And just imagine that I steal Dr. Shapiro's wallet. Now, I acknowledge that I've stolen his wallet, and I acknowledge that I am never giving it back. That is a traditional wallet acknowledgement. Now, Dr. Shapiro's job is to reconcile himself with the fact that I've taken his wallet. That's truth and reconciliation. Miigwech.
Thanks, Tom. All right, so that is our different land acknowledgement. I completely agree, Tom. I think that, just reading a regular land acknowledgement becomes just a bit of, sometimes I worry it's some tokenism. So I'm happy to have a different one this morning. So we have Dr. Adam Shapiro presenting today. And Dr. Shapiro is an associate professor of pediatrics in the Division of Respiratory Medicine at McGill University Health Center and an associate investigator at the Research Institute of the McGill University Health Center. He completed his undergraduate studies at the University of Virginia and medical school at McGill University in Montreal. He completed his pediatric residency and pulmonology fellowship at the University of North Carolina. He is the creator and director of the first and only clinic for primary ciliary dyskinesia in Quebec, as well as the medical director of the North American Clinic Site Network for the Primary Ciliary Dyskinesia Foundation. He's also the committee chair of the American Thoracic Society sponsored clinical practice guidelines for diagnosing primary ciliary dyskinesia. And the title of his presentation today, Detecting, Diagnosing, and Treating Primary Ciliary Dyskinesia in 2023. Over to you.
Thank you so much. I realized I said 2023. I changed it to 2024 on the screen.
Oh, yeah.
So.
You know what? I meant to ask you that same thing, actually. I was going to say, hopefully it didn't just end in 2023.
I was a year behind. I apologize. So thank you guys so much for having me today. And thanks to Dr. Kavesi for having me in his office and not stealing my wallet. I actually have my disclosures here, which you can see I'm involved in several PCD-related companies and foundations. So there you are.
Sorry, we need your slides. We need your slides. We can't see your slides, Adam.
Oh, sorry. I'll let Tom try and help me.
Apologies. All right. Just be a sec here.
Looks good. That's your screen, Tom.
Yep. PowerPoint will be up in a sec here.
Perfect.
Good now?
Yeah, that's great.
No problem. So there's the disclosures for everyone to see. Oh, now I see myself on the screen. Okay, good. Okay, so we're going to talk about identifying classic PCD, and I really want to convince you guys this is not a rare disease. You've probably all seen it and didn't realize you had seen it. We're going to talk about how to diagnose it once you've seen it and picked it out of the needle out of the haystack, and then we're going to talk about some outcomes and new therapies that are on the horizon. So in order to understand PCD, you have to understand the airway. And the airway from the back of the nose all the way down to the terminal bronchioles is lined with respiratory cilia. And each epithelial cell has 200 cilia extending from it. They're floating in airway surface liquid, and they sweep back and forth to take mucus, to take debris like inhaled antigens, pollution, viruses, bacteria, caught in the mucus on top of the airway surface liquid, and they move it up like an elevator, and you swallow about 10, 20 times a day, and that's how you defend your airways from all the bad things you're inhaling. And again, there's 200 of these little cilia per cell, and you probably remember way back in embryology on the first day of medical school, they showed you this cross-section of the ciliary axoneme, and you thought you'd never see it again, but it's back. And so what we look for in a normal ciliary axoneme structure is the 9 outer doublets surrounding a central pair, which you can see right there in red, the outer and inner dining arms, which provide the motor for the cilia to beat. The radial spokes, necks, and links and dining regulatory complexes allow stabilization of the cilia so that it beats in a linear fashion. And the disease primary ciliary dyskinesia is actually a very old disease. It was first found in 1904 by Dr. Siewert. So it used to be called Siewert's disease. And then in 1933, Manus Cartaginer, a Swiss scientist, actually realized that there was a triad of symptoms of situs inversus totalis, where the organs are flipped, bronchiectasis, and sinusitis. But it wasn't until 1976 that Bjorn Afzelius, who you can see right here from Sweden, realized it was due to cilia and called it immotile cilia syndrome. That name was changed in 1981 because we realized the cilia are not immotile. They just beat in a different dyskinetic fashion. And then in 1994, another Swedish scientist named Dr. Lundberg actually found that nasal nitric oxide was low in patients with PCD. And then about 25 years ago, we had the first gene found. Shortly thereafter, the PCD Foundation, which is a patient advocacy group in North America, and the premier research group, the Genetic Disorders of Mucociliary Clearance Consortium, were founded. And since then, we've now had 2 RCTs. We now have a PCD Foundation patient registry, and we now know there's over 55 genes that cause this disease. So quite a lot of advancement in the last 20 years. And this lady, Michelle Mannion, is the mother of a PCD patient who actually founded the PCD Foundation and started a lot of the movement here. She did not like the fact that people told her your kid has a rare disease, it will never be researched, and there's nothing you can do about it. She took that as a personal challenge and has done decades worth of work on this. So in primary ciliary dyskinesia, you have a defect in the mucus clearance mechanisms from the upper and lower airways. And the cilia are dysmotile and stiff. So you see here's a wild type, meaning a normal ciliary beat pattern. And you can see in certain genetic defects, you can have a decreased amplitude of the ciliary beat, or you can have almost no beat. And this is from a genetic origin. That's why it's called primary ciliary dyskinesia. You've all had secondary ciliary dyskinesia. When you go outside, it's -30 and your nose starts to drip. Your cilia are paralyzed from the cold. And this stagnant mucus that develops that can't be moved by the cilia starts to get infected and inflamed, and you get this vicious circle that you see in lots of mucopurulent lung diseases like cystic fibrosis, PCD. They're all the same pathway, but the way you get there is very different. So PCD is very, very hard to diagnose, mainly because people don't look for it. Common things are common, and people say you just have recurrent viruses, and there's nothing more to it. But these kids actually suffer. They have severe hearing and speech impairment from very chronic and purulent ear effusions from day 1 of life. They have a very poor quality of life from infancy and in preschool. If you think about it, we do a lot of comparison to cystic fibrosis because that was our kind of baby in pediatric respiratory medicine. And kids with CF don't suffer much. Most are caught with newborn screening. Once they're on enzymes, they're pretty good and their respiratory symptoms aren't bad. With PCD, imagine having the worst cold of your life every single day of your life from birth. That's what these kids have. And eventually the ongoing bronchitis and pneumonias lead to bronchiectasis, which is an irreversible airway dilatation, which you can see here in the middle, early bronchiectasis, and later severe bronchiectasis. And some patients will go on to respiratory failure, death, or needing lung transplant in their 40s. So it's by no means a benign disease as it has been described in the past, and people often misdescribe it even now. It's mainly an autosomal recessive disease, and the prevalence was thought to be 1 in 30,000, but new prevalence estimates based on 29 genes and how they're reported in various databases show it's actually 1 in 7,600. If you compare that, cystic fibrosis is about 1 in 2,000, so it's not nearly as uncommon as we thought. And if you look at all the cases and projected from that 1 in 7,600 in the US and Canada, there should be 50,000 patients with it. but less than 2,000 are definitively diagnosed. And if you start looking at certain populations that are highly consanguineous, or there's a founder gene, such as the Pakistani population in Great Britain, it is as common as cystic fibrosis. Unlike CF, which predominantly affects white children overall, PCD affects all races, all countries. It does not show a predilection for white children over non-white children. And it's really not that rare. If you think about it, all of these other diseases here, Ehlers-Danlos, SMA, Rett syndrome, hemophilia, they have a prevalence of about the same rate as PCD. But all of them have very distinct phenotypes, meaning the symptoms that you see are easy to recognize and highly specific. And the problem with PCD is it looks just like daycareitis. Everyone in this room that has had a young kid in daycare at some point could say, God, my kid looks like PCD. And it also looks like cystic fibrosis, immune deficiency, bad asthma, aspiration. It looks like everything we see in general pediatric and respiratory clinics. And that's the problem. You have to pick a needle out of a haystack, find that 1 in 7,500 kids that may have this. And so we realized this back when I was in my fellowship in North Carolina, and we started the Genetic Diseases of Mucociliary Clearance Consortium with over 9 sites around North America. And we had patients referred to us from all over who had a high clinical suspicion of PCD. And we did a very detailed cross-sectional phenotyping and diagnostic visits. And we were able to show that in the 300 patients that we could diagnose with definitive PCD, every one of the symptoms started very, very early in life, if not right at birth. So this did not wait until you were a year of age to come on when you started daycare. You have daily year-round wet cough, 99% of the patients. And when I say daily year-round, it never goes away, even in the summertime. You have daily year-round nasal congestion in near 100% of the patients since birth, never goes away. Recurrent otitis media and recurrent pneumonia and bronchitis are very prevalent, but they're also very nonspecific. And what we started to find that there were some more specific phenotypical features, such as neonatal respiratory distress and situs anomalies, organ situs, meaning organ placement, that were affected more often in children. Whereas adults can't really tell you if their cough is year-round since birth. They don't remember, but they know they have bronchiectasis, chronic sinusitis, and male infertility and female subfertility as well. So I just want to go into a little bit of the phenotype that I think would help you as pediatricians try and pick this out. And as I say these, everyone thinks, aha, I had a case like this in the NICU. But the neonatal presentation is actually quite specific in PCD. This is a nice retrospective study looking from Toronto where they looked at 46 of their PCD patients and went back to when they were born. And they could show that the neonatal respiratory distress in these PCD patients was extremely delayed at about 12 hours of age when it started, compared to controls that had transient tachypnea of the newborn, where it presented right away. The duration of oxygen need was extremely prolonged in a term baby versus those with transient tachypnea or neonatal pneumonia. And many of them had lobar collapse. So you see a collapse here. This is the right upper lobe because this baby has situs inversus. Again, the right upper lobe, you've got right upper lobe and lingula. And so lobar collapse with a delayed onset of neonatal respiratory distress in a term baby is highly specific for PCD. We actually at McGill have had about 20 patients diagnosed at birth now, and we've had 4 that were preterm, and we actually wanted to look at preterm versus postterm. And even though these are very small numbers, there's actually some quite telling things in here. The first is that the atelectasis in both groups is delayed in onset. So many of these babies, and you can see down here, this is a 24-weeker that was born, had fairly clear lungs after they were intubated and got surfactant and quickly extubated in the first 24 hours of life. And then at day of life 5, they started developing the atelectasis that persisted for about 100 days. And what you can see in the neonates that were premature, it persists much, much longer. The other interesting thing we found was that about 25% overall of these babies have prenatal brain ventriculomegaly. And I'm going to talk about that a little more in the future of this study. But there are ependymal motile cilia in the brain that help to regulate cerebrospinal fluid flow. And it seems that in some patients with PCD, that doesn't work very well. And while very few get hydrocephalus, we do see prenatal brain ventriculomegaly in these patients, and it resolves by the time they're actually born. And that's exactly what we saw in these cases. So the other more specific phenotypic feature we have is situs. So situs solitus is your heart's on the left, your stomach's on the left, your liver's on the right, probably what everyone on this call has. And situs inversus totalis is a complete mirror image. but you can actually get any defect known to man, any direction, any malformation on a spectrum between these two. And we call that spectrum situs ambiguous. And it's different than what the cardiologists call situs ambiguous, but this is how we've termed it. You can get right atrial isomerism where you have two right lungs, two right atria, two right ventricle, and asplenia. You can get left atrial isomerism with two left lungs. You're missing your SA node because you have two left atria and polysplenia. But you can also get anything in between. You can get isolated defects of dextrocardia with PCD. You can get intestinal malrotation. You can get polysplenia or asplenia and absolutely no other defects. You can have bilateral SVCs or interrupted IVC, and you can have renal and liver issues such as a horseshoe kidney or midline liver. So basically, when you're looking at a patient and wondering, could they have PCD, an abdominal ultrasound and an echocardiogram are your best friend, because if there's any kind of malformed organ or misplaced organ in any of those compartments, PCD goes much higher on your list. And when our cardiology colleagues come in, they actually refer to something called heterotaxy. And heterotaxy is when you have scrambled organs plus any of these severe heart defects that I've outlined in red here. But the problem is some kids will have completely normal hearts and have an interrupted IVC with a midline liver and polysplenia, or they might have absolutely no heart defect and just have abdominal defects. So if you're just looking and saying, oh, it's got to be congenital heart disease, you'll miss cases. And if you're just looking and say, oh, well, it's got to be congenital heart disease with a splenic issue or something in the abdomen, you will miss cases as well. And the reason this happens is because there's different type of cilia in the body. And I've been talking about motile cilia of the airways in the brain, but you have to realize there's embryonic nodal cilia. So when you're a small cluster of cells at around age 12 weeks, your body has to break symmetry and actually tell the cells to form a left-sided heart or a right-sided liver. And that's what these embryonic nodal cilia do. They propel fluid from one side of the nodal plate to the other. And if you're missing a protein, say in one of these dynein arms in the embryonic nodal cilia, it might spin abnormally and misplace and malform organs. And then you'll be missing that exact same protein in the motile respiratory cilia after birth and develop PCD. So this is much better in person, where I can actually ask you to guess the star's situs. There are some very famous people out there with situs issues, and I can't tell you if they actually have PCD or not. But the first one is Enrique Iglesias, and he actually has situs inversus totalis. I do not know if he has PCD, but some of my nurses were willing to perform his spirometry if he comes in person. The other one, Shaun White. So he was an American snowboard gold medal winner. He actually has tetralogy of Fallot, which we term under situs ambiguous per PCD, although no self-respecting cardiologist would agree with this. But we do actually see tetralogy of Fallot in animal models with PCD and gene knockouts. So it actually happens within that spectrum. There'll be a few more throughout this that you can guess at, and I'm sorry you can't yell out in person, but feel free to type in the text if you think you know the star's situs. So this is perhaps the most important slide of the presentation. And basically what this shows is that there are hallmark symptoms that can help you as a clinician pick out PCD from your clinic. And so the first thing you need to realize is people with PCD are probably the sickest 5% of your clinic. These are the kids that are always calling you, always infected, always having issues. And the four things that will really help you are unexplained neonatal respiratory distress with a supplemental oxygen need or CPAP need for more than 24 hours in term infants, early onset, meaning before 6 months, year-round wet cough, never ever goes away, always present, even at the height of summer, even after antibiotics, it's present. Early onset year-round nasal congestion, again, never ever goes away, and any organ laterality defect. If you have 2 of these, it's 80% sensitive, and that's the kind of person you would then send on to your respiratory colleagues here at CHEO and say, hey, does this kid have PCD? If you have all 4 of these, it's 99% specific, and you know right there you've basically made a diagnosis of PCD that needs to be confirmed through genetics or electron microscopy, which I'll talk about. Now notice what's missing from here: severe otitis media and pneumonia bronchitis. And why is it missing? Because again, it's so nonspecific, it's in every kid we see. But if you've never ever had a history of ear infections and you've never ever had ear effusions, the chances of PCD are very low. But still, it could be possible with these clinical symptoms. So once you've picked the kid out that you want to actually diagnose and work up PCD, and how do you diagnose it? Now, the problem is there's a lot of different tests, and not all tests detect all cases of PCD. And in fact, 20 to 30% of your supposed or probable PCD population will end up having inconclusive testing, and you just have to treat them clinically. The tests that we use in North America really are genetics and nasal nitric oxide. Electron microscopy is now a second-line test, and I'm going to show you why. But these are the two tests, EM and genetics, that really help you to absolutely confirm a diagnosis. Whereas a nasal nitric oxide testing can be very, very suggestive, but it's not a true diagnostic criteria just yet. So when you do electron microscopy, you scrape some cells out of the back of the nose. It's not that much worse than a COVID test, and everyone understands that now. And you look for absence or shortening of dining arms is the main thing. So here you can see the 9+2 doublets. With the outer dining arm is a hooked comma, which you can see pretty easily. The inner dining arm is much harder to see, but it's there. Here's an example where the outer dining arm, the hooked comma is missing, very easy to see. Here's one where the cilia are naked, missing their outer and inner dining arm. And here's one where the central apparatus is disorganized with microtubule disorganization. And the problem is, we know that this is a real cause of PCD, but you can also see this after a virus when you're rebuilding your cilia. And in fact, if anyone's ever seen old English sheepdogs that are very snotty and full of congestion, many of the pure breeds actually have PCD with situs inversus. Pure breed means inbred, consanguineous. And it actually showed us that this disorganization, which we thought might be post-viral, is actually due to the genetic defect that happens in these dogs, and we found similar ones in humans. So it's important to realize electron microscopy can be completely normal in 30% of genetically proven PCD. And if you're at a center, even the biggest centers in the world mess this test up. One huge center in New England, very important center, couldn't even get 40% of their electron microscopy to the point of having usable EM, usable cilia to look at. So if you're not doing 20 plus of these a year in your path lab, you are not doing it correctly. And the problem is you also get a lot of background interference, a lot of secondary inflammatory changes. So they're really only the class 1 defects, which I've listed here, are actually diagnostic of PCD. So here's another guess the star situs. Does anyone know this one? So the first is Sean Connery. He has situs solitis, but the second is Dr. No, and Dr. No has situs inversus totalis. In one of the James Bond books, he's actually shot in the chest and survives to come back to try and kill James Bond in the next book because his heart is on the other side. It's actually commonly used in literature. And what about this guy? I'm dating myself because I know who he is. So I hope there's some people with grayer hair than me that know who he is. But this is Donny Osmond, kind of a Mormon tabernacle singer family from the 1970s. And he actually almost died of ruptured appendicitis because it was on his left side and they kept saying he had diverticulitis. So he has situs inversus as well. So I've shown you that electron microscopy is not very good for diagnosing PCD. Well, how about genetics? So genetics is actually coming into vogue, and it's because of the massive amount of genetic discovery that's gone on in the last decade with whole exome sequencing and other novel genetic diagnostic techniques. The problem with PCD is it's many, many different genes. And if you compare this to cystic fibrosis, which a lot of us in the respiratory world understand, the CFTR gene here in pink has 27 exons. It's not that big a gene. And it's taken us over 40 years to understand all the different changes that can be pathogenic or non-pathogenic. Now look at all of the PCD genes lined up here. Some of them are massive. So you can see it's a huge amount of data to go through to try and say you do or you don't have PCD. Most of the genes are autosomal recessive, but there are some that are X-linked and some, even one that's autosomal dominant. So it makes it very tricky to try and use genetics. So if people say, well, what is the pickup of genetics? I say to them, well, it depends on who you're testing, who's in your population. Of course, like any disease, the most common and well-funded countries find the genes first. So in whites from European countries, PCD genes will pick up about 82% of patients. But this will be completely different if you're in the Middle East. And depending on what the most common genes are in your population, if they're not included in your gene panel, you'll completely miss patients. And that's what actually happened in our French Canadians in Quebec that I'll talk about a little later. So really, your genotype will differ per ethnicity in your population. And if you have the right genes on your panel, you might catch it or you might miss it. So if we actually divide the genes by what electron microscopy defects you expect to see, all of these guys over here cause classic PCD that you can actually diagnose on electron microscopy. However, in the last 2 decades, it's all of these guys that show non-classic EM or normal EM that have now come to the forefront and really kind of pushed us to do better in PCD. About 6 of the genes cause 50% of PCD in general. And this gene, Haydn, was one of the genes that we found in our French Canadian population. So about 30% of our French Canadians carry this gene. And this gene is not included on most panels and very, very difficult to actually investigate due to a pseudogene somewhere else in the genome. So it's very important that if you're actually testing for this, you're using a panel that includes the Haydn gene, especially because that border between French Ontario and French Quebec is pretty artificial, and it's the same genes pervading throughout. The other thing that I have to teach people about all the time, as respirologists, we're very bad at using genetics. You need 2 disease-causing mutations in the same gene. You can't have one in CCDC40 and one in RSPH1. And you have to make sure those genes arrive in trans, meaning you often have to check parents. And you also have to make sure they're pathogenic or likely pathogenic variants per the American College of Medical Genetics. You can't use variants of unknown significance to make a life-changing diagnosis in someone. And most importantly, you cannot rule out this disease with negative genes, because they might have a variant that you haven't discovered yet, they might have a gene that hasn't been discovered yet, or they may even have an intronic variant, which we're starting to find now. So you can get panels that include most of these genes, and many of them include CF and immunology genes, and people are doing whole exome sequencing. But again, all of this is only as good as the person interpreting it. So you really need advanced genetic support with really good geneticists that understand this disease to actually diagnose it correctly. Now, as pediatricians, I want you guys to be aware there's a few syndromic forms of PCD. There's RPGR, which is an excellent form, and that gene not only causes retinitis pigmentosa, a form of retinal degenerative blindness, but also causes PCD because there's cilia in the eye and in the lungs that are linked. Orofacial digital syndrome is another excellent gene where you get PCD. Kids with lissencephaly who are very, very delayed due to absence of gyration and sulcation in their brain, and you might think, oh, they have aspiration, they can have PCD as well. CCNO, M-situs, and FOXJ1, of those 55 PCD genes, these are the only 3 that result in human hydrocephalus. So if you have a patient with hydrocephalus who also has chronic cough and nasal congestion, you need to think about this. And Cri-du-Chat syndrome is another one that has PCD, and it's fascinating because they don't actually inherit 2 copies of a mutation. They inherit 1 copy in DNAH5, so they're carriers, but their other copy is taken out by the 5p deletion. And so you have these kids with bad heart defects, which is part of Cri-du-Chat, recurrent lower respiratory tract infections, which you blame on aspiration from Cri-du-Chat, and recurrent otitis media, which you blame on Cri-du-Chat. But it can be they actually have PCD and Cri-du-Chat, and we found that in a few patients. It is quite rare, I will tell you, though. So the other thing that's been really astounding in the PCD world is that we have found this in First Nations here in Canada and the US. And the reason this is important is because First Nations patients, as Dr. Kavesi would tell you, have very poorly characterized and very poorly understood lung disease, but it is severe with very, very high rates of bronchiectasis. And so we were able to find in 4 First Nations across Canada and the US that children affected with PCD had a shared homozygous deletion in DNAL1. And this is an incredibly rare gene that has only been found in 2 Bedouin families in the Middle East. Not the same variant, but we have the same gene here in Quebec, here in Canada. And if you actually look at the ancient migration patterns where they use the language of the Algonquin and Cree to trace where they went, it matches perfectly for the Cree background that we see in all of these different First Nations. We have also found this with Dr. Kavesi's help, or leadership, I should say, and Julia Hunter, who was one of your fellows here, or residents here, that our Inuit are disproportionately burdened with PCD. We've now found about 10 cases since the publication of patients with PCD who are Inuit, scattered throughout the entire area of the Inuit. And we even have an Alaskan native with the exact same variant. And they have a homozygous pathogenic variant in the gene DNAH11 that actually results in normal electron microscopy, which may be why this was missed for so many years, because that was the mainstay of PCD diagnosis. And it turns out this may be incredibly common in the Inuit, with Dr. Kavesi estimating 1 in 1,400 affected in Nunavut and 1 in 19 being a carrier, which is more common than cystic fibrosis in white populations. And we do newborn screening for CF. So this is a plug, and we actually have a call later today to discuss how are we going to address this issue in the Inuit. It doesn't explain all of their lung disease or all of their bronchiectasis, but it's a major contributor. So anyone know this? Any basketball fans? This is Randy Foye, played for the Clippers. He has situs inversus totalis. And if you're a good Canadian, you should know who these people are. This is from Best in Show, but they were also in Schitt's Creek. So Eugene Levy has situs solitis, but Catherine O'Hara actually has situs inversus totalis. So I managed to get a Canadian slant on that. So I've shown you genes are not great. I've shown you electron microscopy is not great. So what is pretty good in addition to those? And it's nasal nitric oxide. So nasal nitric oxide is a colorless, odorless gas that you produce all over the body. It's in very high concentrations in the upper sinuses. And for some reason, it's very, very low in PCD, and no one really knows why. But if it's often 1/10 of what it is in a healthy control. And it's a really, really good screening test, and it's a pretty good diagnostic test, especially when you've ruled out other causes of purulent lung disease and the genetics and EM are negative. So these are my two children doing it. I still put the little thing to hide their identities because they get mad at me if I use their pictures, but I'm in charge of them, so I can. And this is one blowing into a little resistor while this gently sucks air out of the nose and doesn't hurt at all. And here you can see this is my son when he was 4 doing the same thing with a different type of resistor. You want to close off the velum so they don't dilute the nasal sample with gas from the lower airway. You can see it's not painful, it's non-invasive, it's as quick as doing spirometry. It's inexpensive per person. It costs about $7 for the disposables. The machine itself is about $50,000, but it pays for itself in our single payer system because you're not doing 50 to 100 electron microscopy and genetic tests a year, and the results are immediate. You don't have to wait 3 months to get them. And we actually studied this intensively in our research consortium throughout North America. We evaluated a lot of healthy controls, disease controls in PCD patients, established an ideal cutoff of 77 nanoliters per minute as the most diagnostically accurate level. We use this prospectively for 155 referrals at 6 of our North American centers, and PCD was below the cutoff of 77 in 70 of 71 patients, giving an incredibly high sensitivity and specificity. But you have to look at the year this was done, in 2013. And you also have to look that most of these patients were diagnosed by electron microscopy, not genetics, because we didn't know a lot of the genes back then. And now, if you look at all of the genes we know and have discovered since then, all of the ones in red can have nasal nitric oxide above the cutoff of 77 nanoliters per minute. Now, in many of them, it's not normal. It's not 200 to 300 like it would be in you or I. It's like 95, 105. So still kind of in a gray zone, but it can be above the cutoff. So it's important we recognize that. And so we now know that a low nasal nitric oxide occurs in about 90% of PCD overall, and it's much lower in those with classic abnormal electron microscopy defects. And if you have normal EM, it's going to be not as good. There's some limitations. You really need a kid to be more than 5 years old and cooperative with this, but we can do it down to 2 years of age with a tidal breathing technique, although it's not as robust a cutoff. You have to be without a viral infection for 2 weeks. And these are the snottiest kids in the world, right? They're coming to you for daycare-itis. So sometimes I have to say, I can't tell, you're fooling me. Come back in June and we'll see you then. You have to have special chemiluminescent devices, which are not officially Health Canada approved, but we have some ways to get them anyway. It's not a great device. It's finicky. You need approved protocols. And we actually have a PCD Foundation approved protocol that we train sites in. And it can be low in about 1/3 of cystic fibrosis. So you absolutely have to make sure you've ruled out CF, which you would in a kid like this anyway. And can it be low in other disease controls? We found a few very rare genetic immunodeficiencies where it can be low. So it's important that you think about immune dysfunction and rule that out as well. So this is my last guest, the star's situs. I don't know if anyone's familiar with Honey Boo Boo, but her father, Mike Sweaty Sugar Bear Johnson, actually has situs inversus totalis. I believe he gets run over by a lawnmower in one episode and has to go to the hospital and comes back and says, "They done told me my heart's on the wrong side." And I can say that because I'm a Southern boy. None of you guys have the ability to make that joke. Okay. So if you look at the overall diagnostic algorithm for PCD, this is what we wrote for the American Thoracic Society. If you have 2 of these 4 key clinical features that I told you about earlier, and you have access to a chemiluminescence nasal nitric oxide device in the patients over than 5, that is the preferred pathway to do nasal NO measurement as the first screening test. If you don't have that, but the phenotype is strong, then you go to genetic panel testing. If your nasal nitric oxide is repeatedly low, i.e. you've repeated it a couple times and know it's not low just due to a virus, and you've ruled out cystic fibrosis, you have PCD. We still want you to go forward and figure out what gene or electron microscopy it is, because if we had stopped at the sweat test 50 years ago with cystic fibrosis, we wouldn't have discovered the CF gene, we wouldn't know all the things we know, we wouldn't have these life-saving therapies. But if you cannot diagnose them based on electron microscopy or genetics, you really have to make sure they don't have a funky immunodeficiency. So we'd highly recommend they see an immunologist. If you just go straight to genetic panel testing and they have biallelic variants in a single PCD gene, you're done, they've got it. If they have single variants or variants of unknown significance, then you can move on to electron microscopy. But I would caution you, pathologists think they can do this. They cannot. You have to be doing really 20 plus of these a year to know what you're doing and do it correctly. And again, if you can't diagnose them that way, you need to make sure they don't have immunodeficiency if you're just going to treat them empirically for PCD. So when I came to McGill I've been there since 2012, when we started in 2014, as our friend Kevin Costner says, if you build it, they will come. We built a PCD clinic and a PCD referral network. And our colleagues here at CHEO are nice enough to send me patients, especially the very, very difficult ones. They never send me the easy ones. And we've had over 500 consults as the only clinic in Quebec. And we've diagnosed well over 100 people with this now, including 20 children at birth. And now when you come to the Montreal Children's and look at our inpatient wards, there's no CF on it. The CF patients are all much better with their modulators and therapy, but it is full of PCD. We have 3 to 4 PCD admitted at least every month, and they are very sick patients. Imagine CF 20 years ago when you didn't have any approved therapies and you're kind of winging it all and doing it based on style. That's kind of what we're doing. So briefly, I want to talk about outcomes, and we're going to have time for questions after that. So the problem with PCD is people could ask me, oh, is their life shortened? Are they sick? And up until 2010, we couldn't say anything. The only data we had was out of Denmark, where every patient in Denmark goes to the center in Copenhagen. They followed their patients for 10 years. And they did standard stuff that any good respirologist would do. Check their lung function, check their sputum cultures, give them antibiotics when they're sick, do chest physio and get the mucus out. And about a third got worse. About 2/3 were stable and 10% even improved in their lung function. You can see it's extremely heterogeneous. And you start to wonder, well, in a disease where there's 50 different genes, are there some bad genes and some good genes? And it turns out, yes, there are. This was a very large longitudinal study through our GDMCC that showed patients with inner dining arm and microtubule defects or the corresponding genetics in CCD C39 or CCD40 are severe when you compare them against other PCD. They have a low body mass index, and we don't really understand why, because there's no malabsorption like there would be in CF. It could be just due to their severe lung disease. They have a lower FEV1, so their lung function's worse, and they decline twice as fast. And you can see this is the gene that was found in the English sheepdogs that have PCD with the microtubule disorganization. So they're much worse, and these patients go to transplant in their 30s or 40s. We've also found severe outcomes in patients with situs ambiguus. So if you have situs ambiguus, meaning organs that are scrambled, often with congenital heart defects, you are much worse than people that have situs solitis or situs inversus totalis. More hospitalizations, worse nutrition, worse lung function, and it's particularly worse in those with congenital heart disease requiring surgery or an anatomic splenic anomaly, such as polysplenia. We think the spleen works in most cases, but we've had deaths from overwhelming sepsis where polysplenia was assumed to be functional and it wasn't. So we now check all babies born with PCD and any splenic issue for splenic function. It's not that amazing that a baby with bad heart disease or scrambled organs would be worse than a baby that doesn't have that. But what it does show is these kids are hiding in cardiology clinics, they're hiding in genetic clinics, and they're hiding in our ICUs, and we're missing them. And if you don't pick them up early and start their PCD therapies early, their staged Fontan repairs and things like that go terribly. So it's very, very important that you think of genotyping all of these heterotaxy patients very early in life and knowing if they have PCD. We've also started to understand the ear, nose, and throat outcomes, which is really the quality of life issue. It drives quality of life in the first 5 years, or the ears and nasal issues in these babies. And so we actually looked at about 50 patients in Montreal and Toronto and compared them against healthy controls and did standardized exams, quality of life measures, and audiology. And even though we think we're two of the best PCD centers in the world in Montreal and Toronto, we were doing terrible from ENT. Only 26% of our patients saw ENT once a year even. And the quality of life in the SNOT 22, which is my favorite quality of life outcome of any score, the sinonasal outcome test, it was much, much worse in PCD, meaning they're suffering from their nasal disease, and their hearing quality of life was bad too. And despite the fact that we should be doing topical nasal therapies in all of these patients, such as rinses and things like that, only about a third were receiving it. Many of them had hearing deficits, even though they reported that they didn't. When you did audiology, they couldn't hear. About a quarter of them had chronic otorrhea after tubes, but the drops actually controlled it well, PRN drops, and 20% actually reported balance issues. And this is actually very important because we tell these patients, exercise, exercise. It's the best form of airway clearance. We want sports stars. We want dance stars. But they're kind of cilium in the middle ear that could be affected because of the overlap with ciliopathy, or it could be just the fluid in their ears. It's hard to do sports and be good at it and enjoy it when you can't stand up straight. And so this is something we're investigating a little more. And then finally, we've developed PCD Foundation consensus statements because none of this is really evidence-based. It's a lot of it is borrowed from cystic fibrosis, but we do say how to treat these people. Daily airway clearance is your friend and you should do it. Many of us do inhaled hypertonic saline because it actually acts as a cough irritant and makes them cough, and they clear massive amounts of mucus when you do this. Anytime they're sick for more than 5 to 7 days, they call us and we give them antibiotics. It's kind of that rule we use in mucopurulent lung diseases like this. We do chest radiography. We get them to ENT early with audiology and have that continued at least until they're teenagers and maybe they don't want to do it anymore. We do quarterly visits in respiratory medicine with pulmonary function, with sputum cultures. We eradicate Pseudomonas when it's there, even though we have no evidence it works or hurts you in this disease. It's bad in other diseases, and we avoid unnecessary treatment. I do a lot of undiagnosing of asthma, a lot of stopping of inhaled steroids because that is not their problem, and we try very hard to avoid lobectomy because it's been shown to actually to worsen outcomes in adults with PCD. So there are a few evidence-based therapies I'll just show you. The first is on azithromycin in PCD. So this was a study done in Europe where they took people with high rates of exacerbations and they put them on azithromycin, and over 6 months it significantly reduced the rates of exacerbations, pulmonary exacerbations, by 50%. And for the fear of, oh my gosh, we're going to create resistance, they actually had more clean bacteria at the end with a lot less pathologic mechanisms in bacteria in their sputum at 6 months. And then there was recently an inhaled ENaC inhibitor, idrevleride, done, which actually hyperhydrates mucus with PCD. And the thought is if you hyperhydrate it, it will help you cough it out better, even though it's not terribly dehydrated like cystic fibrosis mucus. And this was a 28-day study with an optional extension that actually included ivacaftor, which is one of the CFTR potentiators. And what it showed, there was a very modest increase in FEV1 over the first 28 days. But as you increase to the optional extension, that was sustained and improved that increase. It's very small numbers. It didn't affect quality of life or FEV1, but it was very well tolerated, and that was the goal of a phase 2 study, and it's probably going to go to a phase 3 study soon. And perhaps the most exciting is what we're on the cusp of, inhaled mRNA. There are actually phase 1 trials now ongoing in adults in the United States, and we're going to be part of the early phase 2 here. Gene specific, so specific for the DNAI1 mutation. One company is doing that. Another company is doing gene specific for CCDC40. You inhale the mRNA in liponanoparticles, and actually the protein actually gets replaced in the cilia, which you can see here in yellow. The cilia start to beat normally, and it's a sustained effect for over 30 days. So in the next 5 to 10 years, we could very well have gene-specific inhaled therapies that you're doing once or twice a month and getting amazing amounts of correction. We'll see if this actually improves quality of life, improves lung function, prevents bronchiectasis, but it's incredibly promising to have such targeted, specific next-generation therapies for these people already. And so the last thing I want to show you is we're trying to do what cystic fibrosis did 30, 40 years ago, and that's develop expertise in every state and province across North America. And the Europeans are doing a similar effort with this as well. So you can see these are our initial research sites in the Genetic Diseases of Mucociliary Clearance Consortium. And these are our PCD foundation sites where every single one of them is accredited, taught how to do this, has a nasal nitric oxide machine, has the right kind of genetic and electron microscopy support. We've gone to them, we've visited them, they know how to diagnose this, they know how to treat this. And these are adult and pediatric sites. And you can see we've added a site in Vancouver. We're hoping to add a site in Halifax soon, and we're looking for more interested sites. This is the next cystic fibrosis. You are getting in on the ground floor of CF, you know, before other people. This is where we're all going to have to be to do state-of-the-art care in North America for PCD. So in summary, this classic PCD phenotype is what I want you guys to remember. Neonatal respiratory distress at term birth, often with atelectasis, shifting atelectasis, upper lobe atelectasis after a delayed onset, or prenatal cerebral ventriculomegaly. These are things that in the perinatal world should set off bells and whistles in your mind. Year-round wet cough from birth, year-round nasal congestion from birth. The top 5% of your clinic, they're sick as heck. They never get better. That's them. Or any organ situs anomaly. So do abdominal ultrasounds, do cardiac echoes, and see if they have those. When you pick them out, you got to realize it's hard to diagnose, but nasal nitric oxide, which we have in Montreal, it is not available here at CHEO. One day we hope to change that. Detects about 90% if they're above age 5. Genetics is really good for 70 to 80% detection, but you've got to do the right panel. You've got to know what genes are in your population in order to choose that. And none of them rule out PCD, and that's a major issue. About a third of your population you'll be treating empirically, not knowing if they have it, but making sure they don't have other things like immunodeficiency, cystic fibrosis. And then lastly, we're finally getting some good genotype phenotype data, and we're finally realizing who's better, who's worse, and we're finally coming up with disease-specific therapies. So this is just to thank all of the people that have been involved in my PCD foundation journey and clinical journey. And I'm very happy to take questions now. Thank you.
Thank you very much, Dr. Shapiro.
Sure.
I'm sitting here as an intensivist thinking, oh my God, I'm sure I've missed a whole ton of patients that I've looked after that, to be perfectly honest, it never even occurred to me that maybe I should think about PCD. So food for thought for sure. I myself have a couple of questions, but I see a couple of other hands up. So Dr. Batra. Go ahead. Dr. Batra? Not sure they can hear me. Let me see if any
Can you
other
hear me now?
questions.
Can you hear me?
Yes, go ahead. Yeah, go ahead with your question.
Hi. Yeah, thank you very much for taking my question here. I was very much intrigued by the nasal nitric oxide testing, which has got very high sensitivity and specificity. And being if it is less than 77, almost diagnostic, makes me thinking that nitric oxide may have to do something with upper airway. And if we increase the nitric oxide, that might improve the condition. So are there any ways, medical or otherwise, or even sort of natural ways to increase the nitric oxide in upper airway, which could heal the problem?
Yeah, it's a great question. And actually, it's low in the lower airway as well. So if you do an exhaled nitric oxide test, like we do for asthma, it's also low. So there's been several studies where you give high doses of the precursor arginine or other types of precursors, and it will increase ciliary beat in vitro, but in vivo, given to patients, it did nothing. And it's probably just because the half-life is too short of these agents, but also we don't really know if it's a byproduct. We don't know if it's a marker. We don't know if it's a therapeutic target. That's the problem. We really don't know. So far, the limited therapeutic studies have shown no benefit in trying to correct the nitric oxide. It's most likely an inflammatory process, a complex inflammatory process, more than a nitric oxide synthase issue or a nitrite consuming organism issue, and that's all been checked. It does not improve in PCD patients when you open up their sinuses after a FES surgery, so it's not due to physical obstruction. But so far, all efforts to see if it's actually therapeutic have failed.
Any other questions, folks, before I ask mine? Yep, Erica.
Hi there, I'm a neonatologist. Really enjoyed your talk, and I echo Hillary's concerned that, this is a very common presentation in the NICU, and I'm sure I've missed some of these or had advice calls from our level 2 nurseries where they're saying, I've got a kid in O2, ongoing bit of respiratory distress, don't know why, wasn't set up at birth, kind of presented, like you say, 12 to 24 hours after birth. So it's on my radar now. But I'm wondering what, other than having an explanation or a diagnosis for why these kids are doing this, in the neonatal period and early infancy, what should we be doing from a therapeutic perspective? Because a lot of the things you talked about sound like older infant-child intervention.
It's a great question, and people are scared of hypertonic saline. I've started it on 20 patients in the NICU, day 1 of life, when we have situs inversus and rest distress. We know you have this. They tolerate it very well, and they do fantastic. So an obligate nasal breather with terrible, horrible nasal congestion is not going to do well, especially when they catch their first rhinovirus. So we send the babies home from the NICU on hypertonic saline and chest physiotherapy twice a day. And the parents will tell you when they do this mask of hypertonic saline, it is like rivers coming out of the nose. And we think it decreases hospitalization, but we're now looking at that. So we actually have a study that we're combining with Toronto to look at our 20 babies diagnosed at birth who all did hypertonic saline at birth versus their 20 who did not, because it's not a standard of care issue. It's really a style thing. And hopefully we're going to show that that decreases hospitalizations, maybe decreases ear disease, maybe decreases outpatient exacerbations. But airway clearance and hypertonic saline are absolutely beneficial in my mind. And starting them on day 1 does not hurt the baby, especially if you do a little Ventolin beforehand. We use 7% hypertonic. Some people are scared of that and use 3, but we've had no adverse effects from that. And the other key is you've got them, if you've made the diagnosis and they're plugged into good follow-up with their respirologist, it's getting them to otolaryngology right away. So they get tubes early in life and you don't wait till they're deaf and speech impaired at 2 years of age. You start mucus surveillance for organisms. So it's a whole process. But right away, airway clearance helps them immensely.
Fabulous. Really, really great talk. Really, thank you.
I'm going to ask my couple of questions now, Adam. So kind of, I guess, a bit of an expansion of what Dr. Borisiak was asking you. So let's say I have a patient in the unit who's intubated, who I know has primary ciliary dyskinesia. Like, is there any evidence about using maybe early nitric oxide for them if they've got significant hypoxemia? We would sometimes use that in ARDS, but should I think about that early in those patients?
So it's very poorly studied. There's no evidence whatsoever, mainly because they're not picked up until much later in life.
Mm-hmm.
I can tell you our kids with Fontans that sit in the hospital for 9 months and they can't leave because they're always on antibiotics and no one knows. Would that kid have done a lot better with the Fontan if we had done the most aggressive airway clearance ever on them? I'm talking 3-4 times a day hypertonic saline with chest physio, prophylactic azithromycin, things like that. Would we have prolonged their lives or made their Fontan repairs easier? I think yes, but there's no evidence whatsoever. So when I have them in the unit, number 1, I try and get my cardiologist and unit doctors in the unit to think about this. Okay. I think in any kid with any heart defect, you need to think about this, especially the severe like cyanotic defects, like I showed you, but all of them, you need to think about it. And if you're concerned about it, starting hypertonic saline and really aggressive airway clearance is not harmful usually. And so you do that while the genetics are pending.
Okay. My second question, I see that Dr. Sacker has one too, but my second question is, so because I'm sitting here and I'm listening to this and I'm going, my God, I'm going to start ordering a whole bunch of genetics and electron microscopies, and CHEO is going to go, no, Hillary, we don't have any money. Is there a way, understanding that you can't do the nasal nitric oxide on younger kids, but is there a way to do it on a ventilated patient? Nasal nitric oxide?
No,
Not at all, eh, guys?
Okay. And they have to be in their baseline state of health. So I don't know what virus they have, what the inflammatory cascade of being ventilated is.
Okay.
So there's really not. If they're ventilated, usually their nose has been demolished too, because our nurses are really good at suctioning. So you can't get cilia either that are decent. It's genetics. There are many places where every baby born with congenital heart disease is getting fully genotyped within a day or 2. And you could draw that net as wide or as narrow as you want. You could just say the severe heterotaxic type heart defects we're going to genotype, but that's the key. Early genotyping kids with these funny heart defects and scrambled organs is absolutely necessary, and it changes their treatment in the first few weeks of life.
Okay. Dr. Sacker. Hi, man. Do you have a question?
Can you hear me?
Yep. Go ahead.
Okay. Okay. Thank you so much. So another NICU question.
Yes.
As like stated by other colleagues, like how many cases have we missed so far? Because we see a lot. So like we see a lot of these atypical RDS, term babies, 37, 38 weeks. But if they are improving even slowly and then ending up going home without oxygen, is it still like raising a flag for you or no, from diagnostic perspective?
So I'll tell you what Larry Nogi does. Larry Nogi is the genetic neonatologist that really discovered a lot of the surfactant protein deficiencies that have changed how we approach neonatal respiratory distress. He actually puts on their discharge summary, this patient had atypical prolonged respiratory distress. If he develops recurrent otitis media, severe chronic nasal congestion, cough, pneumonia, please consider a diagnosis of PCD and refer to respiratory medicine. And that, I think, is a very necessary thing, an easy thing that costs nothing to do.
Interesting. Thank you so much.
You're welcome.
Take one more question if there is one before we sign off.
I was just going to say, Hillary, even telling the parents about this possibility, so it's on their radar. You know, it may not make it through to unfortunately, to a primary care practitioner. Many people don't have them now, but letting the parents know that this is a possibility so they can tell the next care provider, hey, somebody told me there might be a problem with hair cells in the nose and lungs. What do you think?
I will say the other thing is family history. We've picked up several babies in the NICU that had respiratory distress that wasn't alarming anyone, who then the older sibling, the history was he's 4 and has had ear tubes 3 times and coughs every day, mucus, productive, and has had pneumonia 4 times. And we were able to get that kid in, diagnose him, and then diagnose the sibling in the NICU.
And what should we be doing, Adam, with our kids from Iqaluit? You know, like we get a lot of them who are ventilated and, you know, they're on the ventilators for a long time. And as you know, Tom knows many of them because they've got these recurrent, like, should I be sending, they're in my unit, let's say, should I be sending genetics off on most of those kids if they've got
I think a respiratory consult is the place to start and see if the phenotype is, it's a hard phenotype because there's bronchiectasis everywhere. I do think if it's as common as we think it is, we should be sending a lot of genetics, but I think we need to do that in a responsible way with some very good phenotyping as well.
Last question to Anne. Go ahead, Anne.
Hi, can you hear me?
Yeah.
Yep.
Yeah, no, excellent talk. So we've emailed a few times, but I can't remember if we met in person. I was at McGill, but I do immunology and infectious disease here. This is really great to raise awareness, and I think everybody's going through that mental list of their patients. I'm just thinking now, like next steps for our institution is to kind of meet with all the different pertaining specialties, whether it's like genetics, REST, NICU, ICU, et cetera, just trying to develop a process. But I'm wondering for you, how did it work as you have like raised awareness for the past decade and how it started? Because you don't want a flood of, genetic testing is expensive and it should be used judiciously, same as antimicrobial. But like how did you proceed or criteria, or did they have to have like an immune workup before? Did they have to have ruled out CF before? Did, that kind of process?
So yeah, they all get a sweat test and local immune labs before I go to genetics, unless it's a slam dunk, unless it's a baby with situs inversus and respiratory distress. In that case, they're going straight to genetics. You got to sort through a lot of garbage consults to find the diamond, right? So after I give this talk, like at a general peds conference in Quebec, I'll get 50 consults in the next few months. Most of them just have ear problems or just have cough and nasal congestion, and it goes away in the summer. So I think you can do a lot of longitudinal follow-up from a respiratory standpoint and start to know these patients and realize you're not PCD. I mean, I've never, ever, ever seen a PCD with a normal nasal exam. So if I look at you and your nose is clean as a whistle in July, the chances of you having PCD are extremely slim. So I think it's very important to have them well phenotyped by your respiratory group. I wouldn't go out and start sending genetics here and there with different services. I think you need a central place. So all PCD patients in the province now come to me. And in fact, when we have a baby born with situs issues at another hospital, they're transferred to McGill, even other university hospitals. Now, I can't say that's happening all the time, but it's happening a lot. So I think having one place to funnel everyone through, and it makes sense that that's respiratory medicine, is the place to go.
And
So
Hillary,
we
I
are-
will add, sorry,
Go ahead, Tom.
that from a respirology point of view here at CHEO, we would be delighted if people advocate, or if you happen to know a rich benefactor, to get us an exhaled nitric oxide machine.
Mhm.
There is nothing that we want more than having one of these.
And I'll train you on it. We'll get you certified.
The fact that we have to send everyone where we're really hoping for nasal nitric oxide, which is non-invasive, to
Yeah,
Montreal or Toronto, is heartbreaking.
yeah.
The test is not covered by OHIP, so the hospital has no burning desire to have one. But it would be great. We could also use the test with the exhaled portion of it to help with managing asthma. It would be a great machine for us to have.
Tom, I will donate $50,000 for the machine.
There you go. There you go, Tom. You got your rich benefactor.
Let's
We're at
talk
time, guys. So
let's talk afterwards. It would be wonderful.
I
Yeah.
would like to thank you very much, Dr. Shapiro, for
Thank
that
you.
talk. I mean, I learned so much, and you know, particularly have armed myself with additional answers to trivia questions, which is very important for me. And what you also maybe don't know is you have unintentionally provided Dr. Kavesi with the next song that he is going to write a parody of for our Christmas holiday party. I don't know if you know, but every year Tom writes a parody of a song. And so, of course, Tom, it's going to be Puppy Love this year. And for anybody who doesn't understand that, you weren't around when Donny Osmond was having hits.
And
Thank you so much. Thank you very
sorry,
much,
one
guys.
last final bit of
Enjoy the rest
trivia.
of your day.
All of those songs that say, I can feel your heart beating next to mine, one of those people has to have situs inversus.
That's true. Bye,
Thanks so much.
everybody. Thanks, everyone.
Fantastic.
Remember to do your evaluations.